And obviously, the papers that you have recommended have been shared among most of the attendees. I hope that many of them might have already gone through the papers as well. And I think that many people, sir, go through your recordings. I've seen that after your lecture, there are so many people who go through it and watch the recordings, and then they read your papers again. So it's amazing, sir. You are doing something which is totally, I guess we cannot pay the debt of the knowledge you have shared.
Thank you. Thank you, Noor, so much.
Sir, would you like to check the screen? We will give just a brief introduction, and then the floor will be all yours, sir. Thank you very, very much, sir.
You can see the screen now, Noor?
Yes, sir, it's perfect.
Okay, so so what I'll do
Sir,
is, so I am out now, so you start the proceeding now.
uh, yes, sir, I'm just trying to think that live stream is already on because John Bennett has just texted me. Okay, yes, yes. The live stream is on. So again, thank you very, very much, sir. It's a matter of real honor and pleasure for me and for Dr. Sujan Dong to host this amazing Pak-China webinar series with the masters. And it was, sir, thank you very much for this amazing honor and the privilege you have provided to us, which means a lot to all of us globally. To learn directly from the master, and obviously, Professor Atul does not need any introduction, but for the sake of, for the sake of formality, I'm just saying a few words. Obviously, Professor Atul is more than just a neurosurgeon. He's a researcher and an innovator and a genius in the field. And you have seen he has pioneered so many techniques and has written so many amazing papers and chapters and textbooks and everything. So every one of us is in awe with all of your contributions in neurosurgery, and it's like a dream to have this finally this a chance of learning directly from you, which means so much to all of us, like I have mentioned before, because it really means a lot. So the Professor Goel is currently the head of the department of King Edward Memorial Hospital, and also works as a consultant neurosurgeon at the Liberty Hospital. And it's a real privilege for us to welcome you here. And sir, congratulations again on the very successful conclusion of your very amazing educational event in India. I had the honor of attending it virtually, obviously not in person, but it was so interesting and insightful. And I believe it will be so helpful for every one of us. So again, sir, the floor is all yours, and to take as much time as you like.
Thank you, Noor. Thank you so much for such wonderful words. And my dear Yang Dong is also sitting there with his small little child. And there's no question that it is my proud privilege, big honor, and absolute opportunity to showcase what I have done over the years. I know these webinars are very popular, and I know these webinars are being seen and heard far and wide. And I'm sure it is a big opportunity for me, not only to show the work and also have an opportunity to show what I am doing and what is new in the subject. So let us see now. You can see this?
Sir, perfectly well.
Okay, so what I'm going to present again and again for several times is the concept, which in my view is complete revolution. And I wish I can explain to you what I mean when I say a complete revolution. Central or axial atlantoaxial instability has to be really understood. And let us see how we can go further. So as I have discussed in my last presentation, atlantoaxial joint is a very beautiful, complex joint. It is the most atlantoaxial. You see here, this is occipito-atlantal joint. It has space for so many ligaments, the upper surface. The lower surface is completely smooth and round. It is smooth and round because it caters to a lot of movements. It caters to circumferential movements. And also, if you see in a anteroposterior perspective, it is horizontal. It is a horizontal joint. It is the atlantoaxial joint is the most mobile joint. Atlantoaxial joint is the most unstable joint. Atlantoaxial instability, because it is flat, the joint is flat. The instability may be there, but it may not be recognized for a long time because the head sits on the flat joint. Atlantoaxial instability is the most common instability in the spine. It is most under-recognized instability of the region. On the other hand, occipito-atlantal instability is extremely uncommon. It is the most stable joint of the entire spine. So all of us have to learn atlantoaxial stabilization, because to do a good atlantoaxial stabilization will give a new good life to our patients. To our several patients where we say, no, we don't understand, we know, don't do this, don't do that. We have to, as young and senior neurosurgeons, we have to learn atlantoaxial stabilization. We have to learn the art of opening the joint. We have to learn the art of inserting screws. We have to understand screws. We have to understand this instrumentation. In neurosurgery, we are not taught about screws. We are not taught about facets. We are not taught about bone fusion. So this is very important to learn the art of atlantoaxial stabilization. Now, one thing which I want to begin with, this occipito-cervical stabilization, which is very frequently done all over the world, occipito-cervical stabilization. I have to give one message to you now, that occipito-cervical stabilization, inclusion of occipito-atlantal joint in the stabilization is not necessary. I introduced occipital screws for the first time in the literature in 1987, occipital screws. Then we started doing occipito-cervical fixation, screw in C1, screw in C2, screw in C3, screw in C4. This kind of fixation, as you all know, is very common in the world. But now, if you ask me, occipito-cervical fixation, is it necessary? Is inclusion of the occipital bone necessary, or is it counter-effective? So my answer to that question is occipital bone should not be included in your fixation construct. So this is a big statement that I am making. And for last 20 years, I've never included occipital bone in my fixation construct. Okay, so that is sentence number one. Another fantastic sentence which I have talked about a lot of time, we always see the images, we always see the MRI, and we talk about compression. And decompression is the treatment. So before I begin my lecture, I want to say one very beautiful thing in spine surgery, whether it is craniovertebral junction or in subaxial spine, that compression is not the issue in spine surgery, and decompression is never the treatment. So this is a huge, huge statement to make, and I will make this statement and I will say what I mean by these statements over the course of this lecture and the subsequent lectures. Compression, in my view, is never primary. Compression is always secondary. Compression is always adaptive. Compression is always protective. And compression is indicative of unstable spinal segment. And compression is always reversible. So you can see this statement, a complex of statements which I have made. You please think about these statements. Let us see how we go further. So in spine surgery, there are two types of instability. One is acute instability, sudden injury, sudden, accident and unstable spine. The symptoms are different, the manifestations are different, the treatment is different, the understanding is different, acute instability is different. And chronic instability, instability for 15 years, instability for 20 years, this is different. When there is a chronic instability, there are several natural reparative or protective or adaptive maneuvers that happen. And these maneuvers are secondary to instability. And we have to understand what the maneuvers are natural. And we should handle, ultimately, we should treat the instability. In atlantoaxial instability, I want to, it is very, very important, this slide. When there is chronic atlantoaxial instability, like for 20 years, 30 years, there is instability. What happens is there are secondary maneuvers like Chiari malformation, syringomyelia, external syringomyelia, syringobulbia, bifid spine, C2-3 fusion, platybasia, assimilation of atlas. If I have to count all those things, I have now a collection of 100 secondary manifestations of chronic atlantoaxial instability. In some patients, there is Chiari malformation. In some patients, there are C2-3 fusion. Some patients, there is kyphoscoliosis, short head, basilar invagination is a huge subject. So all these entities which I am mentioning here, you carefully see this slide. As Noor has said, I have a lot of time today to talk. Chiari malformation. So when we see Chiari, we should think about atlantoaxial instability. When we see Chiari and basilar invagination, we should think about atlantoaxial instability. When we see only bifid, it is atlantoaxial instability. When we see only C2-3 fusion, it is atlantoaxial instability. When we see clipal file, when we see platybasia, whether there is compression or not, whether there is any other manifestation or not, whether all these entities are present in isolation or discretely or in combination. So when I show this slide, it is a complete revolution in the field of neurosurgery. Today, if you ask me today, the treatment of Chiari is decompression, treatment of C2-3 fusion is decompression. All this treatment, the treatment is decompression. I am saying that they are secondary manifestation of chronic instability, and atlantoaxial stabilization is the treatment. So chronic atlantoaxial instability and how nature comes in the picture, how divine intervention or protective adaptive features of nature come in picture. And all these entities which are mentioned in the circle are secondary. They indicate instability and they indicate the need for atlantoaxial stabilization. So this is the introductory slide which I am presenting. So when Chiari is present discretely or in association with syringomyelia or in association with basilar invagination, or basilar invagination is present discretely or in association of Chiari or in association with C2-3 fusion or with bifid or odontoidium, all these things, or short head, or when short head is present discretely. Regarding subaxial instability, OPLL, degeneration, I will give my presentation in a subsequent lecture. Today, I will be talking on these clinical entities. So I have written a lot on these things like basilar invagination, syringomyelia, Chiari malformation. All these entities I have related to atlantoaxial instability. Atlantoaxial instability as the cause of Chiari malformation. As we all know, as the whole world knows, that whenever we see Chiari, we talk of decompression. Either we talk of anterior decompression or we talk of posterior decompression. But this article is now the most highly cited article in the field of carie malformation. But as you know, not many people have clearly understood this concept. And so this is my opportunity to present my concept to all of you. So this is tonsillar herniation or carie malformation. And very frequently, in more than 50% of cases, it is associated with syringomyelia. In about 30 to 25 to 30%, it is associated with basilar invagination. In about 30 to 35% patient, it is associated with platybasia. In lots of cases, there is association of assimilation of atlas. Lots of cases, there is association of C2-3 fusion. Bifid arch of atlas, many cases, Klippel file abnormality, platybasia. So many a times, all these things are associated. Like for instance, this is carie malformation. In this case, it is associated with syringomyelia. If you see, there is a big platybasia in this situation. Platybasia is there. There is syringomyelia. There is carie malformation. In this here, there is syringomyelia. There is quite a bit of platybasia. So platybasia is there in quite a number of cases. And when there is platybasia, the exposure of atlantoaxial joint becomes difficult. Other thing that you notice is there is a lot of CSF outside the cord. And this I have labeled as external syringomyelia. This is internal syringomyelia. I have called this external syringomyelia. Other beautiful thing you notice, we talk of tight posterior fossa. Now you see the sulci are large, the fourth ventricle is not compressed, there is a lot of CSF anterior to the brainstem. I call it external syringobulbia. So these are the things that you try to understand. I am saying that there is nothing like tight posterior fossa. I have to tell you that this concept of tight posterior fossa was introduced by me in 1998. I will show you some papers regarding that. In this patient, you see there is a lot of platybasia, quite significant basilar invagination. There is no tight posterior fossa. There is external syringobulbia. There is internal syringobulbia. There is syringomyelia. In this here, we see a big basilar invagination, carie malformation, syringomyelia. If you see, there is external syringomyelia. There is a lot of... So my concept is whether the CSF is present outside the cord or whether it is present inside the cord, whether there is CSF present outside the brainstem or inside the brainstem or posterior to the brainstem or cerebellum or external syringomyelia, they are all same. They are all secondary. They are all protective. They are all adaptive. They all indicate atlantoaxial instability. And atlantoaxial stabilization is the treatment. Don't worry about compression. This compression, whatever you are seeing, is secondary and adaptive. It is not a pathological entity. Now you see this one. Huge platybasia. Huge platybasia. Huge basilar invagination. Tonsillar herniation. Syringomyelia. But still there is presence of external syringomyelia. There is no question, there is no tight posterior fossa. There is CSF here, CSF in front of the brainstem. The fourth ventricle is not seen, but it is not compressed. This is another case of basilar invagination. There is no atlantoaxial instability. Their facets are in alignment. But presence of carie, presence of basilar invagination, presence of syringomyelia, presence of external syringomyelia are clear indicators, in my view, of atlantoaxial instability, and atlantoaxial stabilization is the treatment. Now here the atlantodental interval is quite large. There is tonsillar herniation. There is external syringobulbia, external syringomyelia. whether there is manifest atlantoaxial instability, whether there is no atlantodental interval disturbance, is the treatment different? That is the question. Whether this patient needs decompression and whether this patient needs decompression or stabilization, that is the issue. Now you see here there is syringomyelia, there is external syringobulbia, there is compression, but there is no question. Don't have any doubt. This is secondary to chronic instability. These are all secondary natural protective maneuver. No decompression. Today, as we all know, as all those who are listening to me today, they know that the entire concept is based on compression, what we see on imaging, and the whole treatment paradigm is based on the concept of decompression, either from front or from behind. So there is manifest atlantoaxial instability in this patient. There is external syringobulbia. There is Chiari malformation. There is no tight posterior fossa. There is no evidence of any kind of compression of the fourth ventricle. This is manifest atlantoaxial instability. Many of you may know or many of you may not know, this instability was not considered instability for a long period of time. This was considered to be a compressive phenomena, and decompression was the treatment for several decades in the history of craniovertebral junction. Then there is another entity when there is no craniovertebral junction bone abnormality. There is no basilar invagination, there is no assimilation of atlas, there is no platybasia, there is no bone abnormality. So is this Chiari different from that Chiari? Is this syringomyelia different from that syringomyelia? Is the treatment of this syringomyelia and Chiari different? Is decompression the treatment of this entity? My answer to that question is these are all brothers and sisters of the same father, and that father is one. It is instability. If that instability happens in the fetus, if it happens in the neonate, if it happens in the early childhood, that when it happens, is trauma an initiator of instability? That we don't know. But there are natural protective maneuvers that happen to counter this instability. One thing I will tell you, if you have one patient of Chiari, you ask him one question, is there pain in the neck? He will say pain in the neck is for 10 years or 15 years or 3 years. You touch his neck, you will find spasm of the nape of neck muscles. This is chronic spasm, chronic pain. That is the basic symptom of Chiari malformation. The other symptoms of Chiari malformation is, we know, weakness of the hand grip, wasting of the hand muscles, then stiffness of the legs, difficulty in walking, voice disturbance, breathing disturbance, sleep apnea. These are the secondary symptoms of chronic atlantoaxial instability. Atlantoaxial instability is the cause, whether there is platybasia, whether there is basilar, whether it is present discretely, whether the syringomyelia is present without Chiari, whether Chiari is present with basilar invagination, whether basilar invagination is present as a discrete clinical entity, whether there is bifid arch of atlas, whether there is C2-3 fusion. You see what statements I am making. Believe me or not, they have the potential to completely revolutionize the field of craniovertebral junction. Now you see this patient. There is syringomyelia. There is no atlantodental interval disturbance. There is no facetal malalignment. There is no evidence of instability on these images. But my concept is clear, my concept is definite, and my concept is based on several years of my more than 15 or 17 or 18 years of experience with more than 600 cases of Chiari and more than 4,000 patients of C1, C2 fixation. So I'm talking on the basis of a long and big experience. I have been doing, as I mentioned in the last lecture, I've been doing C1, C2 fixation for nearly 38 years now. So there is syringomyelia. There is no problem here, no little bit facetal malalignment. No question, there is no tight posterior fossa. There is external syringomyelia, external syringobulbia. This patient needs C1, C2 fixation. As we know, the whole world of Chiari is based on what we see on imaging. We see the tonsil as herniated. We see that there is some deformity at the craniovertebral junction. What the whole world is doing today is foramen magnum decompression. But if you see the literature, some people do just suboccipital craniotomy. Some people remove the arch of atlas. Some people remove the C2 lamina. And the indication is as down as it extends with decompression is the treatment. Some people open the dura. Some people do duroplasty. Some people do pericranial graft. Some people do various kinds. Some people do tonsillar resection. Some people do arachnoidal resection. Some people plug the obex. Some people put a shunt here. You see, if you see the literature, it is loaded with how you do foramen magnum decompression. The bottom line, I have also described in the literature, as I showed last time in my lecture, I taught first time in the literature that there is no need to open the dura, just do bone decompression. That is the treatment which I described in 1998. So foramen magnum decompression has been the treatment, and foramen magnum decompression is for Chiari malformation, it is a common form of treatment worldwide. So in about 10, 12, 13 years or 15 years ago, I introduced this paper, Is Atlantoaxial Instability the Cause of Chiari Malformation? And I had presented my experience with 65 patients. Now my experience is nearly 600 patients. And I'm loaded with Chiari malformation from all over the world. As many of you know, when I introduced this article, there was a huge international controversy or discussion. I should not call it controversy, but discussion in the literature, in the form of letters to editor, in the form of various where I had to respond to various kinds of controversy or discussion. The question is, somebody has been doing decompression for 15 years and 20 years, and somebody suddenly from India in a village of, poor country comes and say, oh no, this is the wrong treatment. Obviously, nobody is going to just say, yeah, very good, very good. There was controversy and lot of discussion and lot of arguments and lot of answers which I had to give in the literature. This was an academic debate. And about 4 or 5 or 6 years ago, I published my experience with 388 cases with Chiari. No question. All those who are listening to me, please believe. There is no question in my mind that a revolution in the treatment of Chiari is made. Chiari is secondary. It is secondary to atlantoaxial instability. It is a protective natural maneuver, and decompression is a negative form of treatment in the presence of unstable spine. Even now, I had received letters to editor where I had to reply. So when there is a chronic instability, as I mentioned, there are several natural protective maneuvers. Like Chiari, we call it malformation. Malformation means error in the production. It is a pathology, error, malformation. We said that it is not a malformation, it is a natural formation. So it is a big nomenclature change that we mention in the literature. So this concept of central or axial atlantoaxial instability, on which we have now written several articles in the literature, I wish that you please read them and try to understand them. The other beautiful thing is we talk of radiology. When we talk of imaging, we talk of observations on radiology, on dynamic imaging and all, but even direct physical manual can give you some kind of understanding about instability. So the entire story started with my experience in 1998, where we talked about basilar invagination. At that time in 1998, I have talked about it in the previous lecture, but still listen because I want to develop this story. We talked this kind of entity in 1998, the whole world was treating by transoral decompression, and this kind of Chiari or this kind of basilar invagination, the whole world was doing foramen magnum decompression. Transoral decompression, as we know, is now become historical, but foramen magnum decompression is still quite a popular technique. In 2004, we said that this kind of basilar invagination you can treat by realignment, but this kind of basilar invagination, we also said that you have to do foramen magnum decompression in the presence of Chiari malformation. Open the joint, do basilar, open the joint, distract the facet, and you can reduce this. So this is an unstable situation, which you might not believe the whole world was feeling that this is a stable phenomenon. This is not unstable. And decompression was the whole world. And hundreds of patients were being treated by decompression in the whole world. So this was quite a revolution. This was direct transoral surgery was the treatment, and foramen magnum decompression was the treatment in 1998. And we said that we also introduced the concept. Now you see this 1995, for the first time in the literature, we said that there is no need to open the dura for basilar invagination and for Chiari malformation. Now, many people in the world are doing foramen magnum decompression, but they don't open the dura. But now what my current, after 30 years of this experience, now I'm saying, don't do decompression, don't open the dura. Of course, there is no need to open the dura. So this kind of basilar invagination I have talked about, that open the joint, distract the facet, realign. And this treatment is now very much popular in the world. Some people come from mouth, some people come retropharynx, and realignment has become the norm. And nobody does now transoral decompression. But still, you will be surprised that many people in the Western world in particular still resort to transnasal endoscopic decompression, transoral decompression, transpharyngeal, retropharyngeal decompression. Still for this entity, decompression is the treatment. In my view, which is confirmed, which is definite, which is absolute, that transoral decompression for such clinical entity is an absolutely negative operation. And please, please, for heaven's sake, don't do it. So in chronic situation, nature comes in picture. There are reparative measures like short neck. When there is a short neck, when there is a torticollis. When you see a short neck, it is due to atlantoaxial. You don't have to do imaging. This kind of short neck, this kind of torticollis is due to one entity, and that is atlantoaxial instability. When there is short neck, obviously there is basilar. It is due to chronic. When there is lumbar disc herniation, what happens? There is scoliosis. When there is lumbar disc herniation, what happens is there is spasm in the neck, in the back. Similarly, when there is disc herniation in the neck, what happens? There is spasm and pain, and there may be some kind of a torticollis. But this torticollis, short neck torticollis, is a protective phenomenon due to chronic atlantoaxial instability. What is required is no decompression. You do fixation, the neck will become long and the neck will become The torticollis will disappear in the evening of operation, and you will get such a beautiful smile. So here you see short neck. Look at the craniovertebral junction. Don't start doing decompression. This is an unstable phenomenon. This is a chronic instability, chronic neck spasm. And do the stabilization, and you improve the neck size, you reduce the torticollis, and you give a new human being. You have the potential to give a new human being. Not only neck is the problem, there may be in this boy, I don't remember, but there must be some hand weakness, there must be tingling, there must be weakness, difficulty in walking, there must be several others, several. And if you don't treat this kind of patients, slowly, surely, definitely, relentlessly over the years, these patients will worsen. Patients of Chiari malformation will worsen. There will be a progression of symptoms. In Chiari malformation, sometimes say, oh, there are very minor symptoms, we can ignore it. Oh, there is only pain in the neck, we can ignore it. Oh, there is only tingling of numbness in the hands, we can ignore. No, you cannot ignore. These are chronic situations. These are potentially life-threatening, dangerous situation. This is an unstable situation. You have to stabilize. So when this patient comes with no other symptoms other than torticollis, there is an unstable spine. If this patient, I don't remember this patient, but if there are no other symptoms, but you ask him one thing, is there pain in the neck? He will say, yes, there is pain in the neck. You touch his neck, there will be severe spasm in the neck. If a patient with Chiari comes with no other symptom, you touch his neck, there will be severe spasm in the neck. If there are no other symptoms in Chiari, you cannot say, I don't want to treat him, he does not need treatment. The person needs treatment. Person needs to live with a smile and dignity, and with hands and legs intact, and having a comfortable sleep, and having a comfortable posture. So when you see short neck, these are secondary, these are protective, these are reversible, and these are naturally adaptive kind of processes. And they indicate an unstable spine, and they indicate the need for stabilization. So we have treated several hundred patients now with this kind of neck, and introduced this kind of beautiful long neck. And not only neck, as I mentioned, many of these may be having hand problem, neck problem, limb problem, walking disturbances. Pain all the time in the neck is not a minor symptom in these children. If you have pain in the neck all the time, it is not a minor symptom. It is a major, major disability. If you're having spasm, he's not able to flex his neck for reading, for having a look at the computer. It is a major disability. Of course, this patient was on a wheelchair. You see here, I am not able to show a wheelchair, but this person was on a wheelchair. See the neck, understand his situation. He was not able to move his shoulders and hands. His family was almost had given up on him. But you see, now this boy is having still quite a bit of disability, torticollis, but he's with his family, and the family looks to be reasonably happy. So this was his imaging. The question is whether you can do C1, C2 fixation or not, whether you have the potential of opening the joint or not, whether you have learned that art of introducing bone graft in the joint or not, whether you can avoid the vertebral artery, whether you can handle the venous lakes in this area, whether you can do a solid C1, C2 fixation. That is the issue. You have to understand that we have an unstable situation at hand. You have to also understand that this guy must be having disability, but he's alive. If you do not do it properly, you have the potential to kill this man. You can disable him, further disable him. So you have to do this properly, learn this effectively, learn the anatomy, learn the art of exposure of the joint and do fixation. And you have the potential to give new life. Cervical fusions. Cervical fusions are all, you see, when you see such cervical fusions, there is no compression at the craniovertebral junction. No compression means you cannot say there is no compression, so he does not need treatment. There is no compression. There is no need to do any decompression. Now, this young little girl had come with breathing disturbances, walking disturbance. You cannot say there is no compression, so I don't treat this. The fusion that you see are protective, fusion are secondary to unstable atlantoaxial joint. You do atlantoaxial fixation. You see, if you see the literature, I want you to read the literature. For this clinical entity, nobody is going to do fixation. Nobody is going to do. Many people will do some kind of decompression here. But this patient needs one treatment, and that treatment is C1, C2 fixation. And you can give instantly a brand new, a wonderfully new life of completeness to this person. This is another very high profile daughter of a high profile person. You see basilar invagination, see caries, see syringomalia. What you will do here? See the clipal file abnormality, see the multiple bone fusions. There is no serious compression here. C1, C2 fixation was done, and see the beautiful smile on this patient and on the doctor. I have given a new life to this girl. If you were depending on decompression, if you had done syringostomy, I am absolutely sure you would have killed this girl, or you would have harmed this girl to a great, great extent. Understanding the concept that there is basilar invagination, chiari, syringomalia, they are all secondary. They are all secondary to unstable atlantoaxial joint. C1, C2 fixation is not going to be an easy technique in this. Occipitocervical may be easier technique. You will say there is already assimilation of atlas. Why not do C1, C2 fixation? My answer is you can do occipital fixation in such a situation here. But the best fixation is C1 and C2, the most beautiful and effective and solid fixation. If you want to see such a smile, you have to learn this art. It is not an easy operation. In the presence of syringomalia, in the presence of basilar invagination, in the presence of assimilation of atlas, C2-3 fusion, the C1, C2 articulation is very rostrally located. And when it is rostrally, means up, the exposure becomes difficult, but the treatment is there. You can do a half-hearted treatment and do occipital fixation or do some kind of other subaxial fixation, but it is not the best form of treatment. Similarly, we said, and we have published in neurosurgery, that bifid is secondary to chronic instability. This kind of bifid, you see in this picture now, there is syringomalia, there is external syringobulbia, there is external syringomalia. These are, this patient, I don't remember this patient, but this patient must have come with very, very marginal symptoms. You see, there is bifid. So when there is bifid, these are all chronic process. This patient must be having neck pain for 15 years or 10 years if the person is young. These are all protected. But if you touch his neck, there will be neck spasm. If you ask him there is neck pain, there is severe neck pain. Believe me, my dear friends, many people in the world will still do decompressions here. There is no in dynamics, there is no instability here, but this patient needs one treatment. Without any question, without any argument, he needs C1, C2 fixation. And without any doubt or hesitation, I can say this patient will get a brand new life after surgery. So there is basilar invagination, there is atlantoaxial instability, there is severe bifid here, and a new life has been given. In this beautiful child, chiari malformation, syringomalia, there is no evidence of instability here, no evidence, but there is bifid here, but there is chiari here, but there is syringomalia here. There is no compression. There is must be in alignment. You have to do one treatment, and that treatment is C1, C2 fixation. These are all secondary. These are all naturally protective, chiari, syringes, all these things. Bifid, C1, C2 fixation is the treatment. Multiple bone fusions, presence of bifid, are absolute, no compression. You see, there is no compression. What you will do here? Either you say there is no treatment because there is no compression. But compression, in my view, is a non-issue in spine surgery. Compression, 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 and decompression has become a sight. psychic phenomena in spine surgery. You look at the problem, you look at learn the powers of nature, learn the adaptive powers of the nature and try to understand what the nature indicates. Just don't go by imaging. So there is bifid here, there is severe basilar invagination, there is chiari, there is syringomalia, there is little bit facetal malalignment, but this patient needs one treatment, and that is C1, C2 fixation. Similarly, we said, and this is published in World Neurosurgery, that os odontoideum is a secondary natural self-bone cutting here. Imagine if this bone was here, it would have damaged the cord very severely. I don't know about the symptoms in this patient, but I am sure this patient must have come with very marginal symptoms because the os odontoideum, the odontoid process has been sectioned. I have to tell you still, my dear friends, many people in the world will do decompression for this case. Many people in the world will still do occipito-cervical for this situation. What is required is understanding the art of C1, C2 fixation and do fixation, solid fixation. You give new life instantly to this person. Syringomalia, as we all know, syringomalia is one of the features like chiari, like syrinx, like basilar invagination, like syrinx. Syringomalia is, the whole world was doing decompression for syringomalia. Whole world was putting shunts for syringomalia. This paper of mine was published in 1995. This paper was published in 2000, where we said that syringomalia is natural protective. It is secondary. It may be tumor and syrinx. Remove the tumor. It may be kyphoscoliosis and syrinx. You have to understand this is an unstable phenomena. Syrinx is not a problem. Syrinx is a protection. It indicates unstable spine. Stabilization is the treatment. Tumor, and there is a tumor and syrinx. Don't start working on the syrinx. There is chiari here. Treat problem is syringomalia. Tumor is the problem. Treatment of primary etiology is necessary. Syrinx manipulation is harmful. Dura mater. From Arabic word literature we have identified. Dura is mother. Dura mater means mother. This is mother can hug the child, but it can never squeeze and kill the child. Don't worry about the dura. Don't worry about the arachnoid in tonsillar herniation or tonsil. This is the whole world was doing tonsillar resection and arachnoidal sectioning. It is, this slide of mine is 20-year-old slide, is not necessary. Treatment of primary etiology is necessary. When there is tumor and chiari, remove the tumor. When there is trigeminal neurinoma and chiari malformation, remove the trigeminal neurinoma. When there is spina bifida at the back, you may like to treat this. When there is a big spina bifida, you treat this. It is secondary. When there is severe I am still working on this entity. I will come back to you with an answer for this entity few years later. When there is bone deformity of the skull, you have to treat the bone deformity and not here. So identify where is the problem and treat the problem. Now, this is our issue for today's. There is chiari, there is facetal instability, there is maybe hardly any compression or little bit compression here. Look at the facets. Even if the facets are in alignment, it is an unstable atlantoaxial joint. Do C1, C2 fixation. Now I will show you several cases. Be prepared. Syringomalia, there is no question it is atlantoaxial. If you touch the syrinx, you have killed the child. You have to do C1, C2 fixation. So facets, look at the facets. They are very important indicators of an unstable spine. In subaxial spine, the facetal alignment is vertical. In atlantoaxial joint, it is flat. So in atlantoaxial joint, there is central instability. In subaxial spine, there is vertical instability. I will talk about subaxial instability in my subsequent lecture. Today, I have to talk on atlantoaxial joint, like lumbosacral listhesis. C1, C2 listhesis is the cause of basilar invagination. It is an unstable phenomena. I described this in 1998. This article was published in 1998. So there is basilar invagination, Chiari malformation, syringomalia. Listhesis is the problem, instability is the issue, and stabilization is the treatment. So look at the facets. You can get very beautiful answer. In this situation of listhesis, if you do decompression, I have, to tell you that it is no less than an absolute ridiculous operation. Whether you come from back, whether you come from front, what you have to do is you have to do stabilization. You achieve realignment, but if the realignment is not complete, it does not matter. Instability is the issue and stabilization is the treatment. In this case of basilar invagination, assimilation of atlas, Chiari malformation, syringomalia, no question, no argument. You see, there is listhesis, there is stabilization, and there is a magic, a new life. You have given a new life to this person. This is another case of basilar invagination, syringomalia. There is basilar invagination, there is listhesis, and there is realignment. So this central or axial atlantoaxial instability is a complete revolution in the field of craniovertebral junction. It can be a cause of several clinical abnormality. And more recently, I have published this article in Neurosurgical Focus in 2023. And I wish that you please read it. So let me revise what I had discussed last time. When there is basilar invagination, there is facet can be displaced anteriorly, there is compression, there is instability, and there is stabilization is the treatment. Now the question is this one. There is Chiari, there is syrinx, there is quite a severe basilar invagination. There is no compression. But look here, there is facetal, this is retrolisthesis, this is unstable phenomena. There is no question, do not do. If you cannot do, do not treat. But don't do absolute ridiculous treatment of decompression in this case. The treatment required is C1, C2 fixation in this kind of rostral location is a difficult operation, dangerous operation. But that is the operation we have to learn. The third thing is, even when the facets are in alignment, even when there is no atlantodental interval disturbance, this slide I've shown at least 100 lectures, and many of you have seen it on several occasions. But still, there is confusion in the world of craniovertebral junction. For this kind of Chiari, this kind of syrinx, there is no compression. Don't do decompression. Don't decompress the syrinx. Don't drain the syrinx. There is no problem here. The treatment required is C1, C2 fixation, and the syrinx will reduce in 100% of cases. And the patient will improve in the evening of operation like a magic. So look at the facets. And if you can realign the facets, all right. But that is not the bottom line of treatment. Instability is the issue and stabilization is the treatment. And now I will show you several cases. You see, there is basilar invagination, there is tonsillar herniation, there is C2-3 fusion here. If there is C2-3 fusion, it indicates unstable spine. There is assimilation of atlas, it indicates unstable spine. Whether you see anything else, whether you see tonsillar herniation, whether you see syringomalia, it indicates atlantoaxial instability. So there is a gross abnormality at the craniovertebral junction. There is unstable spine, syringomalia. Decompression is not the treatment. C1, C2 is the treatment. There is no significant compression. There is a big syringomalia. Don't do decompression. Don't do arachnoidal dissection. Please don't remove the tonsil. Please don't remove the beautiful odontoid process. A beautiful anatomical structure. You see the beauty of this bone. Don't try to demolish this bone. These are all secondary maneuvering. You do C1, C2, see how the syrinx goes. And the whole spine has become dangling in wonderland. And the patient dances in divine beauty. This is another case of Chiari malformation. There is no problem here, no problem here, no compression, but this indicates unstable spine. This indicates the need for atlantoaxial stabilization. There is clear evidence of instability, which was not understood earlier in the world of craniovertebral junction. This patient was treated earlier by decompression, and 100% of people in the world, 100%, not 99%, were treating by syringo subarachnoid or syringo pleural or syringo bladder or syringo some kind of shunt. But this is unstable. What you need to do is stabilization, and what you give is a new life. This is syringomyelia. There is big basilar, no compression, no compression. No compression in front, no decom, but this patient is devastated, comes with heavy clinical symptoms. No problem here, no problem. You do fixation. So instability is the issue and stabilization is the treatment. And we have treated several hundred cases of basilar invagination, syringomyelia, Chiari malformations, and various other abnormality. Instability is the cause and stabilization is the treatment. And this kind of decompression is not the treatment. Now see some more slides. There is basilar invagination, Chiari malformation, C1, C2 fixation has been done. There is no significant basilar invagination. There is not much Chiari, but there is syringomyelia, quite a big syringomyelia, not much facetal malalignment, not much odontoid instability. Stabilization has been done. The syrinx has reduced, not very significantly, but the patient must, I don't remember the patient, but he must have gotten brand new, beautiful life. This is another case of basilar invagination and C1, C2 fixation. Some basilar invagination, little bit facetal malalignment. Syringomyelia has reduced, C1, C2 fixation, no decompression of any kind. This is another case of syringomyelia, no significant problem here, little bit facetal malalignment. I have now got a new answer to this. I will discuss at a subsequent stage because still your concepts are being clarified on this facetal malalignment. But whatever is there, do C1, C2 fixation, the syringomyelia will reduce. There is no decompression of any kind. And the answer to this question is C1, C2 fixation. Chiari malformation, no problem here, no problem here. Fixation is the treatment. This is another case of Chiari, little bit basilar invagination, assimilation of atlas, C1, C2 fixation. You see the syringomyelia has reduced in size. This is another case of syringomyelia, no problem here, no problem here, C1, C2 fixation. This is another case of basilar invagination, little bit basilar invagination, little bit tonsillar herniation, no problem here. Assimilation of atlas, C1, C2 fixation. You see the syringomyelia has reduced in very quick time. This was done after 3 weeks of surgery. Sometimes you do after 3 days of surgery, you can get syringomyelia reduction. So syringomyelia will reduce in 100% of patients if you do a scan after 6 months. It will reduce in about 50% of patients if you do a scan after 1 or 2 weeks. Most important and the only important thing is the patient will recover if you have done a solid fixation in the evening of operation, and he will answer to you, "Doctor, I have got a new life." And that answer is in 100% of patients. This is another case of syringomyelia. You see there is manifest atlantoaxial instability. The syringomyelia has reduced. There is development of CSF beyond the cord. So syringomyelia, Chiari malformation, basilar invagination are all nature's protection. They are nature's airbag. And I will show you some more cases here. You see, this is basilar invagination, Chiari, syring, C1, C2 fixation. This is another case of Chiari. No problem here, no problem here. No tight posterior fossa, C1, C2 fixation. Just enjoy these slides. This is immediate post-operative Chiari malformation, syringomelia. This patient, the whole world today, will do foramen magnum decompression. And 80% or 70% of people in the world today will do syringos subarachnoid shunt. Many people will remove this tonsil, the beautiful tonsil. Many people may not remove this beautiful odontoid process, but still there will be some kind of enthusiasm in removing. But do C1, C2 fixation, syringe will disappear, reduce, and syringe will reduce. As I have mentioned, new life you have given to this patient. This is preoperative image. This is syringomelia, not much basilar invagination. There is assimilation of atlas. There is some facetal malalignment. See the syringe reduced, the C1, C2 fixation. This is another case, syringomelia. There is some assimilation. There is some assimilation. There is C1, C2 fixation. You see the syringomelia has reduced. So now I'm talking on the basis of more than 600 patients. And if somebody tries to argue with me, I can understand the situation because we have not really, this is a new concept. This is a revolutionary concept in the field. For syringomelia, decompression is such an easy operation. C1, C2 in this is not an easy operation, but that is the operation. And that gives an absolute, you see, resolution of syrinx and a beautiful new life. C2-3 fusion. When you see C2-3 fusion, when you see clipal file abnormal, when you see C2-3 fusion, when you see assimilation of atlas, when you see basilar invagination, even if you don't see tonsillar herniation, there is only one treatment. You see the syrinx has reduced. There is no compression. And you do dynamic flexion extension images, there is no problem with the facets, no problem with the odontoid process, and you have lost the chance of treatment. This is Chiari, there is manifest atlantoaxial instability. There is some facetal malalignment. There is problem in the facets. You see here, there is osteophytes here. And if you say there is C2-3 fusion, C2-3 fusion is a beautiful, when you see C2-3 fusion, even if you see C4-5 compression like here, you don't have to start decompression here now. The problem is here, all these things are protective and reversible. Now you see this beautiful case I am showing. This is C2-3 fusion. The problem is at C5, C6. Believe me, my dear friend, there is clipal file abnormality. This patient, tell me what this patient needs. There is no compression. There is no compression. This patient does not need any decompression here. This patient needs C1, C2 fixation. This is another patient. There is a problem here. You look at the facet, there is assimilation of atlas, there is bifid. Don't start decompression here. This patient needs C1, C2 fixation. You see what a revolution in the field of this patient has clipal file abnormality. When there is clipal file abnormality, when there is bifid, even if there is no compression here, there is no question, there is no compression here. Little bit facetal malalignment, this patient needs C1, C2 fixation. So this is a different version of spine cells, different version of craniovertebral junction. Presence of all these kind of abnormality are indicators of a special. This is syringomelia. There is some problem here. There is basilar invagination. There is assimilation of atlas. There is a facetal malalignment. There is you see the syringomelia has reduced. I have done only fixation, no decompression of any kind. When there is C2-3 fusion, when there is syringomelia, this is C2-3 fusion, clipal file abnormality. Don't start jumping on any other. These are clear indicators of central or axial instability. Stabilization of C1, C2 is the treatment. This is another case of C2-3 fusion. C2-3 fusion, syringomelia, Chiari malformation. This is after a few months of operation. Only fixation and magic is the clinical outcome. Chiari malformation, facetal malalignment, C1, C2 fixation is the treatment. Syringomelia, there is no basilar invagination in this. Syringomelia, Chiari malformation, facetal malalignment, don't do any kind of decompression. Learn the art of C1, C2 fixation. Syringomalia will reduce after a period of time. So many of these, as you are seeing, so many patients we have done over, and I have the opportunity, God has given this opportunity to give a completely new life. This is syringomalia. See the facetal malalignment. No problem here. Some problem here. Syringomalia, carry malformation. Don't manipulate the syring. Don't manipulate the carry. Don't manipulate the tonsil. You have to do C1, C2 fixation. You see this another patient, there is syringoma, no compression, no problem, no problem. You do C1, C2 fixation, syring disappear. More than anything else, the patient, remarkable. You see, this is completely, all these are indicated. No tight posterior fossa, external syringomalia, external syringomalia, no compression of the fourth ventricle. This is despite the fact that I introduced this word of tight posterior fossa. I am saying there is no question of tight posterior fossa. This is another syringomalia. I can go on showing cases after cases, but you can use syringomalia reduce C1, C2 fixation, Chiari malformation, syringomalia reduce. No problem here, no problem here. C1, C2 fixation. Syringomalia, no problem, no basilar invagination, no assimilation of atlas, no C2-3 fusion, no clipal file, only fixation, some facetal malalignment, and the result. This is another patient. This is another patient with big syringomalia. You see the result. There is no problem here, no problem here, no problem here, just C1, C2 fixation. This is another patient. You see here, what a beautiful, what a revolution. You just try to imagine what a revolution it is. This is syringomalia, this is post-operative, this is fixation. This is preoperative, this is post-operative. There is no little bit here, no problem here, no problem here. C1, C2 fixation. This is syringomalia. This is after some time, I think there is definite reduction here. Whether there is, this must be whatever it is, C1, C2 fixation. This is preoperative. After a period of time, you see the syringomalia has reduced. So as you can imagine, there were many questions asked to me. Question number one that was asked to me is, if there are bone abnormalities, if there are basilar invagination, maybe this is okay. But if there are no bone abnormality, this is not okay. So there were many questions like this asked to me. So I analyzed my literature and my work. So when there is Chiari malformation with no basilar invagination, no C2-3, no assimilation of atlas, nothing, no bone abnormality, and there is Chiari, and maybe there is healing or not. So I published this series several years ago. Now my series much bigger. So you see, there is no problem, no bone abnormality, no basilar invagination, no problem, no problem. There is Chiari and series. So this case, you see, there is no assimilation of atlas, no basilar invagination, little bit facetal malalignment. There is syringomalia, and I have done C1, C2 fixation in the presence of no bone abnormality. In this case, there is no bone abnormality, there is no basilar invagination. So bone abnormality or not, basilar invagination or not, syringomalia, yes or no, clipal file, yes or no, C2-3 fusion, yes or no, assimilation, yes or no, presence of Chiari and syrinx. One issue is, now you see this syringomalia, no problem here. Some little problem here. No, you see, no compression here. I have done only C1, C2 fixation, and the magic is the clinical result. This is another syringomalia. No problem, no little bit problem here. C1, C2 fixation. Syringomalia reduced inside. This is another one. No problem, no problem. Big syringomalia. No real compression. This is another patient. You see huge syringomalia. There is facetal malalignment. There is no atlantodental interval disturbance. If there is no atlantodental interval disturbance, this is the only parameter that indicates unstable spine today in the literature. Nobody really worked on the facets, but whether the facets are in alignment or not, presence of Chiari and serines are indicator of C1, C2 instability. Basilar invagination, indicator of C1, C2 instability. Learn the art of stabilization. You see there is syringomalia, no problem here, no problem here, no bone abnormality here. Do C1, C2 serines will reduce in size. This is another syringomalia, no problem here. Some bifid here. See the syringomalia reduce. See the syringomalia reduce. No problem, no problem. This is another case. Big syringomalia reduce. No, this is C1, C2. This is quite a big syringomalia reduced after C1, C2 fixation. And the patient will recover remarkably. That you have to, you see, C2-3 fusion, when it is C2-3 fusion, don't look anywhere. Don't look at this unstable spine. Look at the C1, C2 facet. They are quite significantly in problem. When there is C2-3 fusion, whether there is Chiari or not, whether there is syringomalia or not, whether there is assimilation or not, it needs C1, C2 fixation. Similarly, short head, short neck, short spine, they are all indicators of one problem. That is the problem of C1, C2 instability. These are not child, these are adults. They are both brothers. And this is of one patient, one, and this is of another patient. Both have severe basilar invagination. Both have severe neck pain. And this is a highly educated technical person. This one is a little bit uneducated, having more weakness of hand. I have treated this guy. I have not yet treated this one. Let me see if I have to treat it. External syringomalia is a real entity. External syringobulbia is a real entity. Chiari and serines. External serines, internal serines, both are parallel. Both indicate unstable C1, C2. Both indicate the need for C1, C2 stabilization. There is, in this patient, there is external syringobulbia, external syringomalia. Here there is internal syringomalia. Here there is internal syringomalia. Here there is internal plus external. So all these are indicators of C1, C2 instability. There is severe instability, internal syringomalia, external syringomalia. There is problem at the C1, C2 joint, it needs C1, C2. So external syringomalia is also present in chronic benign tumor, like meningioma, like schwannoma. You can have external syringomalia, external syringobulbia. Chiari malformation present with sleep apneas, voice disturbances, breathing disturbances, breathlessness, and also on many occasions, eye movement disturbance. They can present with trigeminal neuralgia. They can present with hemifacial spasm. They can present with gastric symptom. They can present with only urinary incontinence. They can present with night bedwetting. Patient with bedwetting in the night, some of these patients may have atlantoaxial instability. So these patient needs to be understood. You see, this patient has 6 nerve weakness, 2 fixation, 6 nerve weakness. So you have the power to give new life. And many of these now, I was also doing foramen magnum decompression for a long period of time. And many of my own patients are returning. But if you ask me, what is your most common operation that you are doing? Most common operation that I am doing today is the whole world has done foramen magnum decompression and the person has not improved, which is expected. And I am treating those patients. Those are my most common operation, which I am doing. So this patient has been done foramen magnum decompression. And then I have done C1, C2 fixation. He had come with large serines and a big issue with multiple problems, multiple operations. This patient has been operated 13 times with various kinds of shunts, various kinds of treatment. And you see, this is a syringe, this is a tube here, and I do the syringomalia reducers inside. This is another patient. There is a shunt here. This patient also operated several times, and then I operate. You see, what I am saying is the concept. And I'm not trying to say the other fellow was wrong or the other fellow was in. what he has done is from the literature. But the literature has to change and the revolution has to come. And people have to understand that Chiari malformation, doing all these kind of shunts and all those things are negative. You see, this patient series reduced not after the shunt, but after the C1, C2 fixation. And this patient, a very high profile person, if you just see this guy, I don't want to show the video, but there was a Rayleigh tube, see the neck now. At the time of discharge from the hospital, the Rayleigh tube has gone. I have removed tracheostomy from preoperative tracheostomy in 5 patients I have removed. Rayleigh tube I have removed in 7 or 8 or 10 patients I have removed the Rayleigh tube. Catheter, of course, has to be removed. And I have given new life to several of these patients. So that is the power I am saying. This patient had come, somebody had done C1, C2, my own student had done. But the patient had not improved. So I reopened. This fixation was not solid enough. I did a repeat fixation. You see, the series has gone and the patient dramatically improved in the symptoms. So here, this is the various kinds of phenomena that you are seeing in C2-3 fusion. This is a syringomalia. Somebody has done decompression and then they see the syringomalia reduced, not after this decompression, but after this C1, C2 fixation. So I've got several, as I mentioned to you, many patients I have done. The other question that I was asked, and you must read the literature, that this may work in adults, this may work in India, this may work in this kind of population or that kind of population, but this does not work in North America, this does not work in Western countries, this does not work in pediatric population. These were the questions, these are written in the literature. You must read the literature. Then I wrote, this was also published several years ago. Now I've got beautiful series of pediatric patients who came with, this is one pediatric patient with syringomalia and Chiari. And I did, they come with sleep apnea as very common symptom, breathing disturbance in pediatric patient, a very common symptom, walking disturbance. And you can have a wonderful child at your hand. You can have a proud mother sitting here and seeing her child running and getting a new life. This is another child with significant problems. You see, basilar invagination usually does not occur in children, but this C2-3 fusion, much very severe problem. C2-3 fusion, now don't start troubling your beautiful little mind in doing decompressions and all those things. This patient needs one treatment, and that is a treatment of C1, C2 fixation. This is another patient, syringomalia, reduced syringomalia. You see, there is hardly any problem here, hardly any problem here. No need for doing any other kind of treatment. This is another child with syringomalia and all those things, and given new life. Another child with bifid, and when there is bifid, when there is only one treatment, whether it is child or adult, whether it is from India or from any, whether it is, now I've seen even chimpanzees getting, I've recently heard that chimpanzee being treated by C1, C2 fixation. You see the literature, you will find one case of Chiari malformation in a chimpanzee. So you see, after this kind of syringomalia reduced, here facets, no assimilation of atlas. This is another syringomalia and reduced. This is another happy little lady. Hardly you see the face, you see the happy face, you see an absolutely wonderland. Chiari malformation, syringomalia. This is another boy. You see the depressed face, you see the powerful hands and face and hands. So it can be present with bifid arch of atlas, even with when there are posterior elements of axis vertebra. Axis vertebra also there can be C1, C2. There can be omohyoid bone or clipper file abnormality. See, this patient has a big bone here. This is called omohyoid. I have called it a cycle stand. Like a cycle, you stabilize your cycle with a stand. And this patient also needs C1, C2 fixation. C2-3 fusion, C2-3, there is a C2-3 cord compression. In C2-3 fixation, I used to do subaxial fixation also, but now there is atlantoaxial fixation is the only treatment when there is C2-3 fusion. There is compression here, but this is secondary. This patient does not need decompression here. This patient needs a C1, C2 fixation. This C2, this huge, there is compression kind of situation here, but this patient needs only C1, C2 fixation. So atlantoaxial instability is when there is only syringomyelia, no problem in basilar invagination, nothing else, nothing else. You have to do C1, C2 fixation. And believe me, my dear friends, a magic, an absolute magic, absolute magic. When you see syringomyelia and Chiari, a lot of these patients have kyphoscoliosis. I will say in syringomyelia, at least 80% patients have some kind of deformities. Don't start introducing multiple screws for this kind of patient. When there is Chiari and syringomyelia and kyphoscoliosis, you have to do C1, C2 fixation. And this was my article long time ago. Now I've got multiple. See, in our business of neurosurgery, in our life of neurosurgery, we can have complications. We have problems. We have got difficulties. We have got bleeding difficulties, vertebral artery issue. But that does not mean we do not understand this situation. We do not try to just ignore this concept. So Chiarians, no problem here. Kyphoscoliosis, don't start introducing multiple screws, which the world is doing still, for your information. This kind of age group. In this age group, my current concept is at least 80% of patients have central instability without any problem. No Chiari, no syrinx, no basilar invagination, no bone abnormality. You identify and understand the central instability. You treat central instability. The deformity will go, the breathing will improve, the patient's limbs will improve. So don't misunderstand or ignore this concept. And the improvement will occur in the motor evoked potential during operation. You do syringomyelia, you do fixation, motor evoked potential will improve during. I have no other proof to say. You see, here if you do decompression, you say, I do decompression. I don't believe in this. There is no atlantodental, no problem here, no facetal. I want to do decompression. I want to I want to open the arachnoid. I want to remove the seating. You do fixation. During fixation, motor evoked potential will improve 40%. So central or axial instability can by itself, presence of bifid, presence of various kinds, syringomyelia, even in the absence of compression, they indicate unstable C1, C2. You do fixation. I think, Noor, that is, I still have some more slides, but I will touch on this rotatory instability. What do you think, Noor? Should I continue or what?
Sir, thank you very much for your wonderful lecture. Sir, I will certainly request you to, if you wish to proceed with it, you are more than welcome. But if you think that if you would like
Okay.
to split it up, then obviously, so whatever you
Okay.
like, we will be more than
Okay.
happy. Thank you
Noor,
so much.
let me continue. Okay, let me continue. So this is, I introduced to you a new concept of rotatory and translatory role of dynamic imaging, okay? So post-traumatic dynamic imaging presenting with atypical symptoms like brain fog, vertigo, trigeminal neuralgia, abdominal symptoms, all these symptoms, and dynamic imaging. So I am showing you this very young man. You see his gait. See how he is walking. You see how he's walking? Are you seeing? No? And there is no compression here, no compression, no problem in the facetal articulation, no problem here, little bit problem here. No facetal malalignment on flexion or extension. So I do dynamic rotatory imaging. You see the facets of atlas and axis? It is complete. On rotatory imaging, the complete, on dynamic imaging, the facet of atlas are completely not in alignment. And I do C1, C2 fixation. And you see the same person who was walking like that. Now you see how he's running. Yeah. This was pre-operative and this is post. The other one. Yeah, okay, come. Now just drop it off. And this fellow sent me that he is now doing boar hunting and all those things. Now you see another patient. There is no compression here. There is no compression here. There is hardly anything. Dynamic imaging. See, the facets are completely in malalignment. This was the first patient before operation. You see how she's walking? See the husband, how he's protecting her.
Okay, go back.
See how she's walking. And now how she's walking after operation. This is immediately after operation.
Go back, go back, go back, turn.
You're seeing this and rotated dislocation on dynamic imaging. This is another boy, no problem here, no, an advocate by profession and having several issues, no problem here. And I do dynamic imaging. See, the facets of atlas are completely malaligned. And I do operation. In the operation, you can see the smile. Of course, he will be talking in Hindi language. Let us see if you can understand.
Better, because I am thinking clearly. He's telling हाँ हाथ और पैर में बिल्कुल भी नमनेस नहीं है, सब कुछ एकदम वर्क कर रहा है, बेटर.
So you see no problem here, no problem here. Dynamic imaging showing complete facetal malalignment, and you give a new life to this person. This was another person from another country. And you see the facetal malalignment on rotatory imaging. I do fixation, and he's now doing very fantastic swimming and went for also hunting. This is another little girl who had no problem here, and an absolutely new life to this. All this tingling, everything is gone to this person. So this concept of rotatory dynamic imaging is here to stay. So this concept of central or axial instability is the future of craniovertebral junction, presence of bifid, presence of syringomalia, presence of neck pain, presence of spasm gives you an indication of unstable spine. You stabilize and you give, you see the hand, and you see this hand, and immediately after surgery, you see the shoulder, you see immediately after surgery. So this is the beauty of craniovertebral junction. You can, absolute revolution. And I hope you try to understand these concepts. Noor, I hope it will be a completely new era of craniovertebral junction surgery. And I will be happy to answer your question. I will be happy to answer Yang Dong's question. I see many people from China participating in this. I see many people from Japan participating in this webinar. Noor, you have made me quite famous in the world, and I will be able to answer any question that you have.
Thank you very, very much, sir. It's a pleasure to hear your phenomenal talk. It was so amazing, and I have received a lot of comments for you in the email, in the chat box, where everyone is greeting you and is really, appreciating your amazing talk. So thank you very, very, very much. And I think, sir, there are a couple of questions, I believe, which are here. And Dr. Yang Dong, I guess Dr. Yang Dong has raised his hand.
Yeah.
Yes.
Yes, Yang, tell me.
Well, everybody know this is the second lecture of this series. And in the first lecture, Prof.Atul has conducted a very comprehensive introduction of the anatomy of the craniovertebral junction and described detailedly the technical nuances of C1C2 fixation in difficult conditions such as the vertebral artery issues and bone abnormalities. And he also introduced a very new concept in treatment for better imagination. And today, Professor Atul brought another new concept, central or axial axial dislocation. I have to say, I have read so many articles on this entity, and I think maybe it's really difficult for many people to understand this entity. And I want to recommend this article to you. Let me share my screen. Yeah. I think that you can see my screen, right? I want to recommend this very new article. It describes detailed investigation for the CAAT, and it can help you have a better understanding of this concept. And I think only when you got opportunities to manually manipulate the C1, C2 joint, then you will get the definite understanding of this concept. And that's all. Thank you for your very fantastic presentation.
Thank you, Dr. Dong. Thank you, my dear. I know you are not very young neurosurgeon. You are a senior neurosurgeon of China now. And you are doing some amazing work. And I wish you all the best. I want you, can you tell me, Yang Dong, how many people from China are watching your show now? You have the figure?
Maybe 1,500. 1,500 maybe. Yeah.
I think that there's a Chinese channel over there. There are two Chinese channel I think over there which are watching. Sir, there are so many wishes for you in the chat box. And again, sir, thank you very much. It was really phenomenal, and you have really touched the basic concepts that is very it is very interesting, and I believe that everyone must have found it very interesting. And sir, I will if there's any question, kindly share it in the chat box. I know we have taken much of your time, sir, so I believe we will keep it brief. But sir, there are a couple of things that I need to mention here. We have lost two very big neurosurgeons last week, and I believe that I really wish to acknowledge both of them, including notably Professor Sandeep Chatterjee, who left us last week, and it was a very untimely demise. I had the honor of meeting him a couple of years ago during the ISBN meeting. He was very active and very academically enthusiastic, and everything that was very inspiring for all of us. So when I came to know about this very shocking news, I was really shocked to think that he has left us for good. But however, he will never be forgotten. He was very dedicated and very smart, and all the time very kind to each and every person. So whoever has ever met him will never forget him. So may his soul rest in peace. And also we have lost Dr. David Klein, who was a very again a very active neurosurgeon with special interest in peripheral surgery, and had all this amazing academic contributions. So it was the AANS and the CNS really honor him and for all his contributions. And there's a special tribute for him as an educator. So I really wish to bring about these two important people, and I believe that every teacher who has contributed in neurosurgery will never be forgotten, and his or her legacy will always live with us in the form of teachings and in the form of training. So again, these were two things that I really wish to add in the meeting to pay my respect to both of them.
Noor, we have indeed lost some beautiful, fantastic educators in neurosurgery, and their legacy, their teachings, their love, their affection, their presence will be felt for a long period of time. And I hope the only way to recognize them, the only way to acknowledge them, the only way to love them, only way to respect them is to follow them, is to understand them and what they meant, what they taught, and how they taught, and how they walked, how they conducted themselves in public, in person. These things are very important for us to learn, to emulate, to go further in our life. We are all fellow travelers. We learn from each other. We learn and progress the way we have to. And Sandeep Chatterjee, of course, was very, very close to me. He was not just a neurosurgeon, he was a celebrity. He was a very good debater. He used to conduct interviews of topmost people of the world, actually. So we have lost. No.
he will be always missed because he was really, really, really inspiring. And I'm so happy that I have the honor of seeing him, listening to him, and all the things that, and also learning from him. So, but obviously, it's the life is very uncertain, but obviously, what we do is what remains. Sir, I'm sorry we have taken a lot of your time, but there is just one question.
No, if there is anybody wants to say anything about the lecture, I think if there is anybody wants to have any questions, I will be very happy to quickly answer. I have, it will be a pleasure because it is a different concept, different version of. I will be,
Exactly.
I will be happy to answer questions if anybody has, and he can come on the screen and ask.
Oh, sure, sir. Sir, if I can just request anyone who wants to ask a question and wants to turn on their mics, kindly raise your hands. And there is a question from Professor Gabriel Vargas. He's a very active professor from Colombia, and he's asking about any technical tips for C1 C2 fixation that you wish that you can share for C1 C2 fixation.
I will invite him to visit me in India, and this is a very important, as I mentioned, C1, C2 fixation. We are not fully utilizing the capabilities of C1, C2 fixation. We have not yet understood the Atlantoaxial instability can be a cause of huge number of problems. So we have to learn C1, C2 fixation in a very solid manner. You cannot just, by anatomy, it is not just anatomy, it is technique, it is understanding the art of hemostasis, understanding the art of, how to maneuver the vertebral artery, how to get the venous circulation, how to handle the C2 ganglion, all these things. So many things are there and have to be an elaborate special session. No, we can have a separate session on C1, C2 fixation, another one, maybe.
Sure, sure. I believe that there should be one separate session. There is a map over there, sir. Please do let me know whenever you would like to arrange the session. I will be so happy to do it because I think many of us really wish to see it. So there is also a question there by Dr. Adnan Mohammed. I asked about the importance of dynamic imaging studies prior to surgery, importance of nerve conduction studies prior to surgery, and intraoperative neuromonitoring.
As far as dynamic imaging is concerned, as I showed, I'm still trying to evaluate this subject in greater details. Still trying to, you see, I have talked about instability on the basis of facets, on the basis of flexion extension dynamic imaging. But on the imaging, on the rotatory imaging, I'm still trying to understand this concept in greater length. And maybe after a few months, I will be able to give you more details about my results on dynamic imaging. As far as nerve conduction studies and all, I don't do them regularly, but intraoperative monitoring may be helpful. I use it quite a number of occasions, but not in all the cases. I don't do intraoperative imaging, but maybe if you are more comfortable, like intraoperative navigation, for instance. I don't do in all cases, but if you are comfortable with navigation, if you can analyze C2 vertebral artery at the level of C2 before insertion of screws, if you think they are essential, they make your surgery safer, you must use it. Why not? If there is technology, we have to use the technology. But on the other hand, we cannot be victims of, imprisoned by technology. We have to learn the anatomy, we have to learn the concept more than we learn and enjoy the technology.
Exactly, sir. You are so right. We have got a lot of, like concerns regarding the robotic, spinal surgery. So, sir, what do you think about this robotic surgery? Do you think that it could be helpful?
What surgery?
So robotic spinal surgery, sir, it has been, many of the people are, finding robotic assistance quite helpful, especially, regarding, screws and everything. They're saying that there's a lot of precision, although the time has not been shortened with the use of robotic assistance. So what do you think could be the role of robotic assistant in spine surgery?
Noor, I don't think I will be able to give you a very comprehensive and clear answer to this question.
It's a developing phenomenon, so I believe that there's no clear answer there.
As far as there is one question that has been asked here as to what do you think will be stable carry and unstable carry. So my answer is all carry are unstable. There is nothing like stable carry and unstable carry. Sometimes carry may be due to tumor. Sometimes it may be due to another issue. That carry is different. That may be a stable carry. But general carry, what we treat carry malformation, syringomelia, and all those things, they are all unstable. Unstable at C1, C2, and need stabilization. As somebody has asked me the need for 3D models, I have described for the first time in the literature 3D models in craniovertebral junction. I use them for very, very complex situations now, but not as a routine. But those who are not familiar with this, see, as I mentioned, I'm doing this technique since 1988. More than 4,000 cases I have done. So I'm very quite fair. I'm not saying still I rule the region. I'm not saying I've become king of this region. Still I lose my breath during operation. Still they become very difficult during operation. Sometimes vertical artery handling becomes terrific in my situation. I cannot say that it is left hand job for me or right hand job for me. It is still difficult. But I have got a little bit hang on this situation. I don't use models, but if somebody is a little bit new in this business or somebody is not very confident in this area, he may use models because they are very effective and they are very, very useful when you use 3D models. And they are very cheap. You see, we made 3D models in about 3,000 rupees, maybe about $30 or $40. So that is the cost of making these models in India. So they should be done. Why not? If you are not happy with the situation.
Sir, thank you very much, sir. So there is also about a question. I want to ask about the time of improvement of symptoms after C1, C2 fusion in case of syringomyelia.
Yes, that is very important. Syringomyelia or carry, I have said that all this, the primary issue is unstable atlantoaxial joint. You see all your patients, when the next patient comes to you of carry malformation, you see the patient and ask him, what is the main problem that you have? Ask him this question. He will say, my main problem is pain in the neck. Second question, you ask him, you touch him, he will be spasm of neck. Then there will be symptom of tingling, paresthesia, weakness of the hands, wasting, weakness of grip, difficulty in writing, difficulty in taking the hand up, shoulder pain, shoulder weakness, difficulty in walking, stiffness of the legs. Change of voice is very important symptom. Change of voice, low volume voice, breathing disturbance, sleep apneas, incontinence during voiding in the sleep. Incontinence of urine is one very important symptom in children. I got one patient who had only symptom of urinary incontinence and craniovertebral junction shows. One patient I got only symptom of kyphoscoliosis, no other problem, having craniovertebral central instability. So it can present with a whole range of symptoms, multiple symptoms. Question is, if suppose a patient comes with only pain of neck, no weakness of fingers, no tingling, but there is a carry malformation, there is a syringomyelia. You cannot say, okay, just go and you are all right. If you have unstable atlantoaxial joint, the symptoms are progressive. They are relentlessly progressive, initially mild, ultimately disabling, then crippling, and then killing. These symptoms are progressive symptoms. This atlantoaxial instability for carry and all those things. Oh, they have no symptoms, I will treat conservative. This kind of attitude should not be there. Basically, what we have to do is, and as I have mentioned, this operation is not easy. You can have problem.
Exactly, sir. Sir, there are a couple of questions and a few people. Dr. Gabriel is also online, and Dr. Muhammad Al Mazayogi is also online. Who want to say? I think they want to say anything. And sir, there are still a couple of questions there in the chat box,
Yes,
which includes one question from Muhammad Esam, who wants to ask any advice when you face a single vertebral artery or a faint V4 segment in one side. Any precaution before posterior C1, C2 fixation?
when there is one vertebral artery anomaly or two vertebral anomaly or abnormal course, abnormal location, one artery is dominant, another artery is less dominant, fusions here, fusions there. You know, there was one article I wish you can read. There was one editorial of mine where I have mentioned evidence of bone formation and evidence of bone fusion is an evidence of unstable spine. Beautiful editorial. I wish, Mohammed, you read this article. So there are various permutation combinations for all permutation of combination. That is the beauty. So yes, atlantoaxial instability can manifest in a number of situations, number of forms, and the treatment is one, understanding the art of C1, C2 fixation.
So there is also one question from Dr. Fakhar Hayat. He wants to ask, what's the earliest pediatric age when C1, C2 and or the CVJ fusion can be successfully done?
I have done 3 days ago. I know 3 days ago, a child of 8 months
I
old.
believe that
3 days
he
ago.
wants
If you
to.
want me to show the pictures, you'll be amazed to see the pictures, but I don't have them right away. There is another question. Muhammad is from Libya is wanting to ask.
Yes. He wants to say something. I believe, Dr.
Yes.
Muhammad, please feel free to unmute yourself.
Yeah, thank you so much. I finally got the hello. Can you hear me?
Yes.
Yes, yes,
Hello,
yes.
hello, sir. Good to see you. I'm very happy to see you. Thank you so much.
Thank
It's
you. Thank you,
amazing.
Muhammad. Tell
As
me,
always,
give me some beautiful comments.
very happy to see you after
Thank
a long time. Yeah, thank you so much. I just want to say something that you keep always saying, that you give a new life to the patient. And I want to say that I am sure that you give us, the neurosurgeon, a new life also. That's the thing that I want to say.
Thank you. Thank you.
Since I went to India, I feel like it's a new life for me as a neurosurgeon. It's a completely, we have changed our life. I have to admit that. Thank you so much.
Thank you, Muhammad. Thank you.
Sir, you are really, really a legend because everyone is so much touched with your teachings and your lectures and your research work. Even myself, I remember myself when I started neurosurgery, I came across all the things that you have written, all those tutorials most of the time, and I can tell you, I was so much inspired. I can just still think that it's so unreal to have you here with us for the news webinar series. Sir, again, thank you very, very much. I believe my camera went out, so I'm sorry
Good.
for that.
Harshad Parikh is there. He wants to say something. Harshad Parikh, you want to say something?
Dr. Harshad, Dr. Gabriel also wants to say something. I guess Dr. Harshad, kindly keep Dr. Harshad. Can you
Professor
please
Abdul, do you hear me?
Hi, Atul.
Hi,
Hi, sir.
Harshad. Yes.
Atul, wonderful talk as usual. Wonderful. You have revolutionized the C1, C2 management. And I have been privileged to witness your surgeries many times. And even this week, somebody was asking you about the age of the pediatric age. And I saw you doing a most difficult case of 10 months old child recently. And you did so fantastically well that the child is doing exceedingly well. So there is no doubt about it. And this revolution of CV junction treatment in cases of whether it is Arnold Chiari or whether it is the syringomyelia, the C1, C2 fixation has to be done. And fantastic talk you have given. And this new concept of rotatory imaging for the rotatory malformation and imaging is something one has to be very, very careful in evaluating these cases. And you may miss this rotatory malformation, and that requires to be fixed. and patients will do wonderfully well. You are always, every time I must have heard you more than 200 times, but every time I feel it's a new lecture. It's a new thing. Wonderful talk. Wonderful. There are no words to give.
Thank you. Thank you, Harsha.
So,
Gabriel?
Dr. Gift,
How are you? Do you hear me?
Yes, Gabriel, yes, I'm hearing.
Okay, thank you. Thank you very much for this, as usual, very wonderful topic. I want to ask you something. You know that we, as Western ideas, we usually do an decompressive C1 laminectomy, open the dura, and all of those things. And in fact, many patients improve on syringomyelia and on symptoms. But I don't know how many patients, but I think that more than 20-30% still with symptoms. So we're planning to do C1, C2 based on your studies. My question is, right now we need to really change our mind and start in all patients C1, C2 stabilization. That's it. No opening, no decompressive, nothing. Just C1, C2 surgery. Is that you teach us today and many times? Is that correct? I understand correctly?
Yes, Gabriel, that is correct. The decompression, which I was also doing for a long period of time, I have to tell you that this concept of tight posterior foci and only bone dissection I described in 1998. And you know what, as I go further in this craniovertebral junction, as I learn and develop this, there is no question. And the kind of improvement, you said that some patient improve after foramen magnum decompression. You know what happens is when you take an incision in the neck, when you tighten the muscles, there is pain in the neck. The patient themselves stabilize the neck for a period of time, 1 month, 2 months, and there must be some recovery of symptoms. But in general, when I was a student, when I was appearing for my board examination, and if I had to answer the question is, why you do foramen magnum decompression? I had to answer at that time, 30 years ago, that I am doing to stall the progress of symptom. I am not doing to improve the symptom. This is the answer that was expected from me. But that is not true. You do a good fixation and you give new life, and an absolutely new life. So this has to be, this has to be understood properly. Only problem is one. Problem is to do C1, C2 fixation can sometimes be difficult. But
yes,
that difficult does not mean anything. You have to do difficult in neurosurgery. Everything is difficult and everything is impossible. But you have to make difficult things less difficult and impossible things possible. And that is our life of a neurosurgeon. We can have problems, we can have difficulty, we can have complications, we can have misadventures, but that does not mean we do wrong things. And we don't want to learn new things. So that, Gabriel, that is the...
Thank you. Thank you very much.
I'm really grateful to you, sir, for your time. And I'm also so grateful to all of the attendees and everyone who has attended and has been watching us virtually on neurosurgical.tv and all those, all those Chinese channels, as well as my own YouTube channel. So I'm again so much thankful to you, and sir, we owe you a lot. And again, thank you very, very much for spending a lot of time for this very amazing lecture, and for answering all the questions. So there are also so many questions which you can see they are popping in the chat box, and they are sending you a lot of thanks, and everyone is so much inspired with you. And personal thanks from Dr. Muhammad Adnan and so many people who are sending you a lot of wonderful messages. So again, sir, thank you very, very much. And I also wish to thank my colleague, my collaborator, Dr. Siu Yendong. And I'm really grateful to you, all of you, for this amazing opportunity. And Dr. Gabriel, he's a very great friend of mine, and I'm so much always grateful for his support and for all the encouragement that he shows. And I believe I'm myself so much blessed to have this privilege of having you all with us. And I personally wish to thank you, Professor Andreas Dimitrios, who is the president of the ENS, who joined us today for this webinar. So I'm really, really, really grateful for him for spending time and for being with us, because
Can we,
teachers like
can we have a small little comment from Andreas if he's there?
yes, I'm trying to actually find him, because that's what I exactly wanted him to say a few words, but I believe he has probably left already. Yes, I cannot find him anymore, but he was there in the start. So I actually wish that he could say something to adjourn our meeting. It would be a huge honor to have him. He's also a huge inspiration for me and for all of us. And like I say, that you people like all of you, we are lucky to have this privilege of getting inspired and learning from all of you. So again, sir, thank you very, very much. And I'm looking forward to your next lecture, and I will be looking forward to knowing the title of your next lecture and what other lectures you would like to share with us, because we are all so much interested in learning more and more from you. And again, thank you very much for spending your time.
Thank you very much, Noor, and bye-bye to all of you. Bye-bye.
Thank you very much, sir. Thank you so much, sir. Thank you all.
Bye. Bye.
Bye-bye, Yangdong. Bye-bye.
Special wishes for your baby boy. Thank you so much, sir.